Welcome everyone. So today's topic of discussion will be chronic otitis media. Chronic otitis media is very important for the student of third professional part 1 MBBS. Suppose a student comes to me a week before the examination and asks me, I have not read anything the whole year. Please tell me the single topic that I should be covering really well. It would be certainly this topic. So, chronic otitis media, the headings on which I'll be talking about are chronic otitis media, definition, the types, the secondary changes, cholesteatoma, the theories of the formation of cholesteatoma, the clinical features of the disease, investigations, treatment, and since this question has been asked many times, both in theory as well as in your viva, so I've put in a separate heading for the differences between the mucosal variety and the squamosal variety of the disease. Coming to the definition of chronic otitis media, now first I'll read out the whole definition, then I'll try to explain the most important points of that definition. Like I'll try to point out the key words that should be present in your definition to make it an ideal definition. So, chronic otitis media is an inflammatory process in the middle ear cleft that results in long-term or more often permanent changes in the tympanic membrane or middle ear cleft, like perforations, retraction pockets, cholesteatoma, oral polyp, etc., and is most likely as a result of acute otitis media with effusion or a negative middle ear pressure. Now, the first important thing, chronic otitis media is an inflammation. So as the name suggests, it's chronic. So the inflammatory process will be like the chronic inflammation. So all the hallmarks of chronic inflammation will be present. Like there will be inflammation and subsequent healing, fibrosis, adhesion formations, everything is present in chronic otitis media. Even if they are not present initially, they might develop. Like alternate healing and inflammation is present together, just like the hallmark of chronic inflammation. And then, so it will involve any part of the middle ear cleft. And then, when will I term a otitis media as chronic? Only when there are long-term or permanent changes. And usually the permanent changes are more often. Like there may be some long-term reversible changes. For example, when I go into details about the secondary changes, I'll talk in details about them. Like suppose a small perforation may heal by itself. So that will be a long-term but reversible change. Then coming to, so the long-term or permanent changes, primarily it affects the tympanic membrane, or it may also involve the middle ear cleft, the permanent change basically. So a few of the permanent changes have been named in the brackets. What may be the changes? Perforations, retraction pockets, cholesteatoma, oral polyp. The others I'll mention when I'll explain secondary changes. And the chronic otitis media is most commonly following an acute otitis media, an otitis media with effusion, or a negative middle ear pressure. Now, chronic otitis media may also develop on itself as well. For example, like what happens in congenital cholesteatoma. Then none of these will be present before. But usually the chronic otitis media occurs following any one of these. So coming to the types of chronic otitis media, I'll be talking about the clinical types of chronic otitis media. Now, we primarily divide chronic otitis media into two types. So what are they? So these are the clinical types of chronic otitis media. One is tubotympanic disease. and the other is atticoantral. So there are certain other terminologies that are associated with these two clinical types of chronic otitis media. I'll name them. So tubotympanic is also termed mucosal disease, and atticoantral is also termed as squamosal disease. Sometimes tubotympanic disease is referred to as the safe type of chronic otitis media, and atticoantral is referred to as the unsafe type. Now, coming back to the names again, tubotympanic and atticoantral. By tubotympanic, we mean tubo means the opening of the eustachian tube. So the tubotympanic disease is primarily involving the area of the middle ear cavity around the opening of the eustachian tube. So that is the antero-inferior part of the middle ear cavity, and it is primarily only restricted to the mucosa. So it is called a mucosal disease. So the tubotympanic tells us about the usual site of the disease, and it is mucosal because it is primarily restricted to the mucosa, and it is termed safe because the percentage of long-term complications of chronic otitis media when this variety of disease is present is very less. So coming to the same thing on the other side, atticoantral. So the atticoantral. So what does attic mean? Attic means the corresponding part of the middle ear cavity adjacent to the pars plasica. And antral, by antral we mean the mastoid antral. So this disease primarily involves the attic and the mastoid antrum, and it is termed squamosal because it is usually associated with Cholesteatoma, which is a squamous epithelium. So it is also termed a squamosal disease, and it is termed unsafe because the chance of causing complications in this type of disease is much higher than the tubotympanic variety. Coming to the subtypes of the two varieties of chronic otitis media. Now, the mucosal disease and this squamosal disease can be further subdivided into, mucosal can be divided into three types, and squamosal is divided into two types. Mucosal disease may be active, inactive, or healed. Squamosal disease can be active or inactive. So when will I call a mucosal disease active? So there will be a tubotympanic variety of the disease, and along with that there will be active infection of the middle ear cavity along with mucopurulent discharge. So when there is presence of discharge in a mucosal variety, I term it active mucosal variety of chronic otitis media. Then, so this is when discharge of pus is present. So, suppose I have treated a mucosal variety of chronic otitis media with proper antibiotics. So the middle ear cavity will dry up, there will be no discharge, there will be a dry ear, but obviously the secondary change, most commonly a perforation, might be present. So the middle ear mucosa will be dry, but the disease is still present. There is no pus, So that is inactive. So the ear is no longer discharging, it is dry. So that is when I term a mucosal disease as inactive. Now what is healed? By healing, I mean spontaneous healing. Suppose a central perforation has healed on itself without any intervention, like surgical intervention. So that is what is usually termed the dimeric tympanic membrane. For example, if this is your tympanic membrane, suppose there was a perforation here, and after that, in chronic inflammation, there is healing and destruction going together. So if the virulence of the organism which is causing the chronic otitis media is not very high and the immunity of the person in question is good, the fibrosis and the epithelialization may heal this perforation. So the normal tympanic membrane will look like this. This part will be healed. So that is termed the healed mucosal variety of chronic otitis media. Now, in case of healed variety, this part of the tympanic membrane becomes very weak. So any change in pressure in the middle ear cavity may cause a huge retraction of the pars tensa. Usually more commonly of the healed part, it can also cause a generalized retraction of the pars tensa. So much so that ultimately the middle pars tensa may go on to meet the medial wall of middle ear cavity and it may get adhered to it. That is what is termed as a adhesive otitis media. So it is very common. It can also occur in any retraction of the tympanic membrane, but it is more commonly occurring following a healed mucosal variety of tympanic membrane. Now this is a dangerous situation. Here we have to perform, usually we have to perform a surgical intervention because the middle ear cavity has become very less in size. Normal functioning will be hampered, and ultimately this can also turn into a squamosal disease. So coming to the subtypes of the squamosal variety, active and inactive, I'll first explain the inactive variety, then it will be easier for you to understand the active variety. So what is termed the inactive squamosal variety of chronic otitis media? So suppose this is your tympanic membrane. Now we know in squamosal variety there is a high chance of formation of retraction pockets. Suppose this part of the tympanic membrane has formed a retraction pocket. Now, if the cavity in the pocket is dry and it is not infected, it may be filled with debris, usually like keratin or even cholesteatoma, but it is not discharging. That will be, and the cavity is more or less dry. So then again, dry retraction pocket. That will be termed as a inactive squamosal variety of disease. Now the same situation, if this retraction pocket is infected, filled with cholesteatoma and is continuously discharging, so that will be discharging. We'll target active squamosal variety of chronic otitis media. So the secondary changes associated with chronic otitis media. Now, as I said many times before, chronic otitis media is primarily a chronic inflammation. So there will be destruction and healing hand in hand. So for the UG student, the primary secondary change that should be known really well is perforation. So I'll talk about perforation in details. So I'll basically first try to explain the types of perforation pictorially. So suppose this is your tympanic membrane, pars flaccida. This is the lateral process of Malleus. Now, what is a central perforation first? Any perforation involving the pars tensor. This is pars flaccida. This is your pars tensor. So, any perforation involving the pars tensor is termed the central perforation. Now, then coming to another type of central perforation which has been classified differently, that is a subtotal perforation. Mind it, a subtotal perforation is an extended central, you can call it an extended central perforation, but it is a central perforation only. Like, so what is a subtotal perforation? It will involve a huge area of the pars tensor, but it will not go up to the fibrous annulus. So, this is a subtotal perforation. Now, why am I saying a subtotal perforation is a central perforation? Now, I said a central perforation is any perforation involving the pars tensor. So, the margins of the perforation is surrounded on all sides by pars tensor only. Now, here in a subtotal perforation also, see, it has not gone up to the fibrous annulus. So, a rim of pars tensor will be remaining. So, this perforation will also be surrounded on all sides by pars tensor. So, subtotal is perforation, can also be termed the central perforation. Then coming to a total perforation. So, this is your pars flaccida. So, there will be almost no pars tensor left. So, the perforation margins will go and involve the fibrous annulus. So, this is a total area of the perforation will be this. So, this is called a total perforation. By total, I mean total involvement of the pars tensor. Then coming to a marginal perforation. Now, so this is again your pars flaccida and your pars tensor. Any part of the perforation which is involving the fibrous annulus will be termed the marginal perforation. Like it has to involve on one side at least the fibrous annulus. So like this is a marginal perforation. This is also a marginal perforation. Even this is a marginal perforation. This is also a marginal perforation. So any perforation which is involving at least on one side a part of the fibrous annulus, we'll call it a marginal perforation. And then another type is the attic perforation. This is your pars flaccida and this is your pars tensor. We know that the area of the medullary cavity adjacent to the pars flaccida is termed as attic. So any perforation involving the pars flaccida is termed as attic perforation. Now, what type of disease are these perforations usually associated with? Now, commonly a total perforation, a marginal perforation and an attic perforation is usually associated with the aticoantral type of the disease or the squamosal disease. Actually, these perforations almost always is associated with an aticoantral disease. Now, a mucosal disease is usually associated with mainly these two types of perforations, the central perforation and a subtotal perforation. Now, an important thing to mention over here is an aticoantral disease may also be present in case of a central perforation or a subtotal perforation, but it is extremely rare. Now, coming to a term about perforation is what is a permanent perforation. Like if you remember in the definition I mentioned about long-term changes and permanent changes. So when will I term a perforation to be permanent? Suppose This is your tympanic membrane. This is your perforation. Now we know that tympanic membrane histologically has three layers: the outer squamous layer, the middle fibrous layer, and the inner mucosal layer. So when the outer squamous layer starts the process of healing, and there is squamous epithelialization around all the margins, and this squamous epithelium of the outer layer will grow into the mucosal layer of the tympanic membrane. So there is overall 360-degree epithelialization of the perforation. So that perforation has no chance of healing by itself. So that is termed. So since it will no longer heal by itself, it will be termed as a permanent perforation. Now, this is the epithelial healing process that again in turn may cause a healed perforation only if the epithelial ingrowth is occurring in a favorable direction. Coming to the other secondary changes, I'll try to speak about them in brief because they are rarely asked. Not rarely asked, like retraction pockets and cholesteatoma are very important, which I'll be describing in details later on. So coming to the other secondary changes, mucosal changes and polyp. So in a tubotympanic disease, the normal mucosal changes that may be associated are mucosal edema, or there may be, in presence of pus, the mucosa may swell up to form what we term as a boggy middlear mucosa. This is in case of mucosal disease. Now in case of squamosal disease, there may be granulations, and of course, if the cholesteatoma has invaded the mucosa, there may be presence of cholesteatoma. Now in squamosal variety, like the cholesteatoma will come time and again, because more or less squamosal disease is most commonly associated with cholesteatoma, and in very few cases the cholesteatoma may not be present. That is when we come across granulation tissue, which is again a hallmark of chronic inflammation. Now the mucosa may turn into a polyp. So polypoidal changes of the mucosa are very common. Now the important point to note over here is oral polyp, which forms in mucosal disease, is usually pale in color, and oral polyp formed in a squamosal disease is usually pink. Now coming to again the ossicular degeneration. So as the name suggests, chronic inflammation has affected the ossicles present in the middle ear. Now the most important point that you must remember in case of ossicular degeneration is the first ossicle to be affected by necrosis or degeneration is the incus. More commonly, the part of incus which is affected first, usually most often, is the long process of incus. So this is the important thing that you must remember in case of ossicular degeneration. Then coming to tympanosclerosis. So what is tympanosclerosis? So chronic inflammation has caused a destruction. So there will be deposits, secondary deposits. Well, suppose when there is deposit of hyalin or hyalinization, followed by whenever there is deposition of hyalin, we can consider there will be a calcification of the connective tissue. after hyaline deposition. So whenever there is hyaline deposition and later on there will be calcification. So that is what we term as tympanosclerosis. Now, tympanosclerosis may involve the tympanic membrane, the promontory, even the ossicles, or even the tendons of the muscles present in the middle ear, namely the stapedius and the tensor tympan. So, the hyaline deposition anywhere in the middle ear cavity followed by calcification will give rise to tympanosclerosis. And as we can clearly understand, because of calcification, the structures will become very hard, the mobility will reduce, so the patient will almost always present with a conductive hearing loss, as the mobility of the structures will be restricted. So retraction pockets and cholesteatoma I will discuss in details later on. And coming to fibrosis and adhesions. So chronic inflammation, and when the healing process starts, suppose the secondary deposition is by fibrin, it may cause fibrosis of the structures of the middle ear cavity. So fibrosis, and whenever there is fibrosis, there is high chance of formation of adhesions in the middle ear cavity. Now, the important point to be noted here is, when there is extensive fibrosis, there may be chances that the opening of the eustachian tube is blocked. So then again, that will cause a difference in pressure along the two sides of the tympanic membrane. So that may go ahead and cause long-term, much more dangerous complications. So much similar for adhesions as well. And then again, if there are adhesions present, again, the mobility of the ossicles and the round window, even the tympanic membrane, will be highly reduced. So that again will again present with a conductive hearing loss. Coming to the next heading, that is cholesteatoma. Now, cholesteatoma is a hallmark of the squamosal variety of chronic otitis media. We're coming to the definition of cholesteatoma. Now, all of the keywords that I'll be mentioning are very important for the definition of cholesteatoma. So, first of all, what is cholesteatoma? It is an epidermal connective tissue structure. So, combination of epidermal and connective tissue, which forms a sac of stratified squamous epithelial outer lining. So, the outer lining of the sac is formed by stratified squamous epithelium and a desquamated keratin center. Okay, so the cholesteatoma structure is mentioned initially, then where will it be present? In the middle ear cleft. And a few characteristics of the cholesteatoma are that it has a capacity of progressive and independent growth, and it involves the bone, replaces the middle ear mucosa, and it has a tendency for recurrence. So the keywords would be, it is a combination of epidermal and connective tissue, and it has an outer stratified squamous epithelium, a keratin center, and it has obviously in the middle ear cavity cleft, and it has a characteristic of independent growth is more important, and it involves bone, replaces mucosa, and it is very commonly associated with recurrence. Here what I want to say is, cholesteatoma is notoriously known for its recurrence. In spite of performing repeated surgeries, cholesteatoma can recur. So an important point that I would like to add, you may be asked a question about this, like the term cholesteatoma is a misnomer. Why? Because although it is termed cholesteatoma, usually we use the suffix oma for tumors. Now, this is not a tumor because the structure suggests it's a stratified squamous epithelium on the outer side and a keratin center. So it is not a tumor. So the oma part is a misnomer, and It also does not contain any cholesterol. So this part is also a misnomer. So the term cholesteatoma, although it has been used for this pathology, it is usually, we can call it a misnomer. So I'll try to explain the theories which are linked with the development of cholesteatoma. Now, there are many theories that have been put forward by different ENT specialists, and so what I'd like to say is there is no one accepted theory for the development of cholesteatoma. There are varied opinions according to this. So before going into the theories, what you first need to know are the types of cholesteatoma. Then we can link the types of cholesteatoma that is best explained by which theory. So what are the types of cholesteatoma? They are of three types: congenital cholesteatoma, primary acquired cholesteatoma, and secondary acquired cholesteatoma. So what is a congenital cholesteatoma? As the name suggests, a cholesteatoma which is present since birth is a congenital cholesteatoma. And the most commonly involved sites in congenital cholesteatoma are middle ear cavity proper, the petrous apex, and the cerebellopontine angle. Now, how does it present? Remarkably, this usually presents with an intact tympanic membrane, and we can see a white pearly cholesteatoma flake behind that intact tympanic membrane. That is the most common way of presentation. However, it is most commonly undetected as the tympanic membrane is intact. So, in certain cases, the cholesteatoma may increase in size, involving bone replacing mucosa, and ultimately cause a perforation of the tympanic membrane from the inside. Then that may present with a discharging ear. So that may be indistinguishable from a mucosal variety there. So that is congenital cholesteatoma. Then what is primary acquired cholesteatoma? Now, primary acquired cholesteatoma is the cholesteatoma which develops in a previously apparently normal ear. What I mean by apparently normal ear is there will be no attacks of previous chronic otitis media. Like, it usually develops because of the formation of retraction pockets. Now, there will be no previous permanent changes, like there will be no previous perforation, there will be no previous attack of chronic otitis media. There may be subclinical infections, but they will not be detected. So that is a primary acquired cholesteatoma. And what is a secondary acquired cholesteatoma? It usually occurs in a chronic otitis media, which is the repeated attacks of chronic otitis media active disease, and there may be a pre-existing perforation. So this is a cholesteatoma that occurs in a pre-existing pathology. Now, coming to the theories, the Cawthron theory best explains the congenital cholesteatoma. What does it say? The cell rests present in the middle ear, which are most commonly present in these three locations, epidermal cell rests basically, they may be present from birth. So they may develop cholesteatoma. So this theory talks about epidermal cell rests. Then coming to Whitmack or Toss theory, this is the invagination theory. Now I have mentioned the name Whitmack before because the invagination theory is more commonly associated with the name Whitman. But in some books, it has also been given as the invagination theory proposed by Toss. So, this Whitman or Toss's invagination theory best explains a primary acquired cholesterol. Why is it called an invagination theory? So, there will be no previous attack of chronic otitis media there, and usually it occurs due to a creation of negative pressure in the middle cavity. So that causes a retraction of the tympanic membrane. Now this retraction will start growing inwards into the middle cavity, and when the epidermal lining of basically the squamous layer of the tympanic membrane may start dividing and changing, and it will basically cause a hyperplasia of the squamous layer of the tympanic. So, if this is your tympanic membrane, so due to a negative pressure created in the middle cavity, a part of the tympanic membrane will retract into the middle cavity. Now, development of squamous epithelium on the squamous layer of the tympanic membrane. So, basically, that will again ultimately develop a cholesteatoma. So, since it forms a retraction pocket which basically invaginates into the middle cavity. So, this is the Whitman's theory of invagination, which best explains the primary acquired cholesteatoma. Now, before I go into Ruedi's theory, I will first explain the Haberman or the Tumarkin theory, because the Haberman or the Tumarkin theory best explains the secondary acquired cholesteatoma. Why? Because the Haberman or the Tumarkin theory talks about epithelial invasion. Now, another, again, a same point to note. I have mentioned Haberman before because Haberman is more commonly associated with the theory of epithelial invasion. So what happens is it is best explains the secondary acquired cholesteatoma. So there will be a pre-existing perforation. Like suppose this is your tympanic membrane. Either it will be an attic perforation or a marginal perforation. Now what happens is the squamous epithelium of the external auditory canal will directly grow into the middle cavity through the damaged fibrous annulus of the marginal perforation or in through the attic perforation. So it is basically invasion of the squamous epithelium of the external auditory canal into the middle cavity. So that again will form a squamous epithelium in the middle cavity, which ultimately will develop as cholesteatoma. So Haberman or Tumarkin's epithelial invasion theory best explains the secondary acquired cholesteatoma. Now, coming to Ruedi's theory, which talks about basal cell hyperplasia.
Really?
What? What is basal cell hyperplasia? So there is a skin in the external auditory canal. Now the basal cells of the lining squamous epithelium of the skin will start undergoing hyperplasia. Now this theory can be linked to both primary acquired as well as secondary acquired cholesteatoma. Suppose that skin suddenly starts dividing fast. It may be on its own, which then will be a primary acquired cholesteatoma, or it may start growing fast due to a pre-existing pathology of chronic otitis media or through a perforation. So the basal cell hyperplasia of the squamous layer of the tympanic membrane or the external auditory canal will start growing fast and will ultimately develop a cholesteatoma. And now coming to the last theory, SADE or Wentz metaplasia theory. Yeah. This theory basically explains what is metaplasia. Metaplasia is the change of one type of epithelium to another type of. This again may explain both primary acquired as well as secondary acquired cholesteatoma. So what is the pathology here? The theory says basically that the mucosal lining of the middle ear cavity will undergo metaplasia to a stratified squamous epithelium. Okay, so metaplasia. This theory was put forward with SADE and Wentz. Then again, why can we link it to both of these? Because if there is no primary pathology, tympanic membrane is intact. There is no previous attack of chronic otitis media. The mucosa may undergo metaplasia and convert to a squamous epithelium. Or even if there is a pre-existing pathology, then also the same thing might happen. So the metaplasia theory can also be linked to both of these types of cholesteatoma. So coming to the clinical features of chronic otitis media, I will try to discuss the mucosal and squamosal varieties separately. Now a few of the clinical features are common over here, like ear discharge. The ear discharge will also be present over here. Then coming to hearing loss. Then perforation. Now, in mucosal disease, perforation is present. In squamosal disease, perforation may or may not be present. So, perforation plus minus. Mucosal changes. Here as well as here. Now, so a few extra clinical features that you might come across in squamosal disease are there will be, might be bleeding. And retraction pockets. Now, coming to the comparative discussion of the two types of clinical features we come across in these two types of diseases. Now, in mucosal disease, the ear discharge is usually profuse. It is mucopurulent and usually on proper antibiotic therapy it reduces. So then after reduction, if proper surgery is not done, it may come again. So it is basically intermittent. And it is usually odorless. Now, the ear discharge in squamosal variety is scanty, continuous. Now, why in continuous, an important point that you must remember, that in spite of giving proper antibiotic therapy, you will almost never get a absolutely dry ear in case of a squamosal variety of chronic otitis media. Now, if suppose a patient who was discharging in a squamosal variety suddenly does not have any more discharge, that is a very dangerous sign, because then you have to perform the surgery, whatever you may need to perform readily, because uh, stoppage in ear discharge in squamosal variety would sometimes, most of the times, mean that the discharge has formed a crust. So basically the discharge can no longer come outside. So the discharge will get collected in the middle ear, and it increases the chances of formation of middle ear as well as intracranial complications. So the discharge is continuous and it is extremely foul smelling. Now the foul smelling is most commonly due to the destruction of bone. Now coming to hearing loss, in mucosal variety, it is almost always conductive and rarely exceeds 50 decibel of hearing loss. Now in squamosal variety, it is primarily conductive, but since there are huge chances of spread of cholesteatoma or granulation tissue, the inner ear may be involved pretty fast, so it can also present with mixed hearing loss. Now in mucosal variety, very rarely we can get mixed hearing loss, although that is if the mucosal variety has caused any complication, and it very rarely causes involvement of inner ear. So here the degree of hearing loss can be anything, and it can be greater than 50 decibels. So the perforation, as I mentioned before, in mucosal variety, it would ideally be a central or a subtotal perforation. Now perforation in squamosal variety may not be present. More commonly it is associated with a total, a marginal or an attic perforation, and even with a central or a subtotal perforation, if there is middle ear cholesteatoma, there may be a squamosal variety of disease. And also the perforation might not be present. That is in case of retraction pocket formations. Okay. So coming to the mucosal changes, the mucosal changes in mucosal variety will develop a edematous mucosa. Very rarely it may form polyps. So those polyps are usually pale polyps. Now mucosal changes in squamosal variety can very commonly form granulations, and the polyps are pink. Now there may be associated bleeding, which is also due to granulations, and obviously during otoscopic examination we may come across cholesteatoma flakes and obviously retraction pockets. So coming to the investigations that you would perform in a case of chronic otitis media, the first thing that you must perform is a examination under microscope. So in examination under microscope, this is basically corroboration of our otoscopic findings. So nothing more to discuss in examination under microscope. In mucosal disease, we will see a central perforation, the mucosal changes. In squamosal variety, we may come across cholesteatoma. We can see the type and type of discharge basically. So examination under microscope is the first investigation that you must perform in a case of chronic otitis media. Then is pure tone audiometry. Now, some important points that you must remember about pure tone audiometry is, why do we perform pure tone audiometry? So, to know the degree of hearing loss. So basically, the amount of decibels of loss that the patient will present with, we need to know the degree. Then the type of hearing loss, whether it is conductive or mixed. Because if there is a mixed hearing loss, we might suspect an involvement of the inner ear. So that patient is a more important patient to undergo early surgery. So degree of hearing loss, type of hearing loss, and another important thing, it serves as a medico-legal document. Like the degree of hearing loss present before the operation and after the operation. So if we can perform a comparison of the two pure tone audiometries, that will help us to prove that the surgery was necessary, because post-operatively the PTA will return, if there is only conductive hearing loss, return to more or less normal levels. So it serves as a medico-legal document, and of course it also helps us determine the success of our surgery. Then coming to tympanometry. Now, in tympanometry, the types of curves that we most commonly come across in case of chronic otitis media, since primarily it is a conductive defect. So the type of tympanometry curve that we will be getting is a B-type curve. And in very rare cases, if there is thick build-up of pus in the middle ear cavity, we may get a C-type curve. Then coming to X-ray mastoid. Now, X-ray mastoid will help us to know the type of mastoid hair cells. And will help us to know about more or less an idea about the middle ear anatomy, so we can be safe during performance of the surgery. Then another important thing that we must remember is the culture sensitivity of the pus. So the culture sensitivity of the pus present in chronic otitis media. So normally the organisms which we come across in chronic otitis media are Pseudomonas, Staph aureus, E. coli, although rarely, even sometimes Proteus. These are the aerobes, and very rarely we may also come across anaerobes like Bacteroides fragilis or some anaerobic streptococci. And finally, in selective cases, we may need to perform a high resolution computed tomographic scan or HRCT scan of the temporal bones. Now this is usually performed when we are anticipating a mastoid surgery along with tympanoplasty. Why the HRCT temporal bone is necessary? Because then we may be able to determine the extent to which the cholesteatoma or the granulation has spread in the middle ear cleft, and also any bone destruction, any ossicular necrosis, everything we will be able to know well, and of course we'll know a will get a very good idea about the anatomy of the middle ear cleft. So the surgery will be relatively easier to perform. Like suppose there may be a contracted mastoid, so in those cases surgery may be difficult. So if we perform a HRCT temporal bone beforehand, it will help us and be a very good guide during our surgery. So coming to the treatment of chronic otitis media, again I'll try to explain treatment of mucosal disease and squamosal disease separately. So the treatment of mucosal disease, most commonly a mucosal disease which is associated with the central perforation. So initially, it is better to go for a proper antibiotic course and oral toileting to clean the discharging ear and to make it dry. So the initially there will be a medical management. By oral toileting and proper antibiotics to get a dry ear. Now important point to note over here, certain small perforations, small central perforations can be treated by chemical cauterization. And the commonly used agent is TC. Now, after achieving a dry ear, the treatment is not completed over there because the central perforation is still existent and it is usually a permanent perforation. So we have to go for a surgical management. And the surgery that is performed most commonly in mucosal variety is a tympanoplasty. Now the details of tympanoplasty will be explained in a separate video. Very rarely if there are oral polyps and mucosal changes, we may need to perform a cortical mastoidectomy in a mucosal disease as well. That is very. So coming to squamosal variety, again here medical management has very little role because you will very rarely achieve a dry ear. You will almost never achieve a dry ear by medical management. So it is better to go for surgery as early as possible. So a surgery in case of cholesteatoma or even granulation tissue, you almost always have to combine the tympanoplasty operation with a mastoidectomy. So the treatment is mastoidectomy with tympanoplasty. Now, mastoidectomy will also be discussed in detail in a separate video. Now, an important point that you must know about mastoidectomy in case of treatment is it can be for treatment of squamosal disease. It is usually of two types: a canal wall up procedure and a canal wall down procedure. Now here, what do we mean by the canal wall? It basically means the posterior superior part of the bony external auditory canal. So if that bony external auditory canal, the posterior superior part is intact, that is what we call a canal wall up or a intact canal wall procedure. And when we remove the posterior superior part of the bony external auditory canal. That is when we call the canal wall down. So, coming to the last heading, that is mucosal versus squamosal disease. Now I have touched all of these and at one point or another in my main video. But however, this question is very commonly asked both in theory as well as in your practicals. So I have made a chart. So to look at the points in which I'll be making the comparison is the discharge in mucosal, it will be profuse, mucoid and odorless. In squamosal, it will be scanty, coolet and foul-fed. So perforation in mucosal variety is usually a central or a subcutaneous perforation, and in squamosal it is usually a total marginal or a acute perforation, and as I have mentioned in the video as well, there may be no perforation or even a central or a subcutaneous perforation may present in a squamosal disease. So granulations are rare in mucosal variety and they are commonly present in squamosal variety. Oral polyp is very rare in mucosal variety, but if present, it is usually pale in color, and in squamosal variety is red and fleshy or pink and fleshy. And Cholesteatoma is obviously absent in mucosal disease and it is present in squamosal disease. Complications are rare and they are very common in squamosal disease. So the type of hearing loss in the mucosal disease, it is mild to moderate conductive hearing loss. And if the internal ear is inward, it may present with mixed hearing loss in squamosal disease, and it is primarily conductive. So the surgical treatment in mucosal disease is primarily tympanoplasty, and in squamosal disease is mastoidectomy along with tympanoplasty. So an important phenomenon that I need to mention with respect to chronic otitis media is the round window shielding effect. So it is usually present in a case of chronic otitis media with perforation. So normally what is the normal hearing mechanism? So this is the tympanic membrane perforation that I have shown in the case of chronic otitis media. Suppose the tympanic membrane was intact. So the vibration of the tympanic membrane would be ultimately through the ossicles will be transmitted to the oval window. So basically these vibrations will be transmitted along the cranium up to the round window, which will ultimately cause the changes in the organ of cortex and will cause the nerve stimulation, the auditory nerve stimulation. But what happens when there is perforation? When there is perforation, the sound directly acts on the tympanic membrane as well as it directly acts on the round window. So vibrations will be transferred to the oval window as well as the round window. So what will happen now is there will be initiation of perineum vibrations from the oval window as well as from the round window. So what will happen ultimately? So these two will come to the helicotrema and cancel each other out. So ultimately there will be no effective vibration of the perineum. So the organ of cortex will not be stimulated. So in presence of a perforation, when both the windows will be vibrated, the person will hear less. Now suppose in a discharging the area around the round window is suppose filled with pus. So what will happen then? So there is presence of thick pus over here. So the vibration will fall on the tympanic membrane, at least the remnant of the tympanic membrane. And although the sound waves will pass through the perforation, but they will not be able to vibrate the round window because the area around the round window is covered with pus. So then again, only the oval window will be stimulated with the vibrations. So then again, a vibration in the perineum will be created and the phase difference will be in there.
So then again the vibrations of the organ of Corti will be stimulated. So what happens is, in a chronic otitis media, when there is active discharge of pus, sometimes the patient may hear better. So hearing is better. In presence of pus. However, in the inactive phase or in the dry ear, the hearing will be less. Now, it may not happen in every patient, but in some patient you may come across this phenomenon when there is pus, the patient hears better. So why does this happen? Because the round window is covered, the area of the round window, around the round window is covered with pus. So basically the round window is shielded with pus. So this phenomenon is called the round window shielding effect.